There. So, as we've done every morning, I'd like to just get body, mind, and spirit in the same room at the same time so we can really learn together and of course, grow together as a community of learning. So, invite you to uncross your legs, place your feet flat on the floor, find a comfortable place for your hands, gently close your eyes or soften your gaze, and just bring awareness to sound and listen to the sound of the bell. And hold your awareness to sound for a moment, noticing sounds that perhaps you weren't really aware of before. Maybe bringing awareness to, are there sounds from inside the body? Maybe a ringing in the ear or digestion. And then bringing awareness to this room, noticing sounds that you weren't aware of before. And then extending awareness. Are there sounds outside this room that might be available to you, accessible to you? And having brought awareness of sound out, let's now bring awareness of your breath, bringing that focus into the breath. And by now you know what to do, so I won't provide any guidance, but we'll do it for about a minute, then I'll ring the bell to end. And perhaps as we bring this short centering to a close, finding an intention for the day for yourself. What would you like? Maybe a single word, focus or gratitude or industry or ease, whatever feels like you need today. Just hold up that intention to increase the chance that that can be yours today. So today's lecture is a bit of a heavy one. It's how do we communicate serious news to patients? And my sense was that having a mindful moment together was particularly important before launching into a topic that, honestly can be rather sad. And some of the hard work we do as physicians is communicating to our patients that their lives just aren't going to be the same from this point on. I like to start talking about this topic by projecting and reading to you a poem. And the poem is by a man named Raymond Carver. He was an American poet, lived in the Pacific Northwest. I think it was either Washington or Oregon. I can't remember which. But he was a hunter, a fisherman, a drinker. a smoker. I guess you might say he was kind of a man's poet. But like many smokers and drinkers, he sadly passed before his time of cancer, in his case, lung cancer. In his last book of poetry, called A New Path to the Waterfall, included a poem that he called What the Doctor Said. And it was his recollection of the day in his primary care doctor's office, where he learned that he had metastatic cancer. And for me, this poem sums up the transcendence that can occur when a doctor and a patient truly connect, and how important these moments are, and how important it is to be good at it, to get it right. And that's what I hope today's workshop will do. So it's called What the Doctor Said. He said it doesn't look good. He said it looks bad, in fact, real bad. He said I counted 32 of them on one lung before I stopped counting them. I said I'm glad. I wouldn't want to know about any more being there than that. He said, are you a religious man? Do you kneel down in forest groves and let yourself ask for help when you come to the waterfall, mist blowing against your face and arms? Do you stop and ask for understanding at those moments? I said, not yet, but I intend to start today. He said, I'm real sorry. He said, I wish I had some other kind of news to give you. I said, amen. And he said something else I didn't catch, and not knowing what else to do, and not wanting him to have to repeat it and me to have to fully digest it, I just looked at him for a moment, and he looked back. It was then I jumped up and shook hands with this man who had just given me something no one else had ever given me. I may even have thanked him, habit being so strong. This is one of the most powerful poems I know that for me distills the importance of this work and the fact that it's not just doctor and patient, but something else can come into the space, something transcends that moment. I'll refer back to it a little bit as we go on. So what I hope you'll get out of this today is knowing why communicating serious news is important. My hunch is that almost all of you probably do already know that, but it's worth kind of knowing what the literature is on it. I'm going to share with you a 6-step protocol for delivering serious news. That was one of the 3 pocket cards that you received, and we'll be referring to that today. So go ahead and pull it out if you haven't. Um, and let's see, we won't be able to practice today, but I want to just share. I will show you a demonstration, though, of a serious news encounter on video. So how would you define serious news if you think about that? We used to call it bad news, and then for a while in medical education, it was called difficult news. But now I think the better term is serious news. How would you define that, thinking about your future lives as physicians? There's no wrong answer. So if just you have an idea, just shout it out for me. News that won't be received well by the patient. I love that. Yeah, exactly. A kind of the literature says it's news that's unexpected and unwanted. You hit the lottery, might be unexpected but wanted, but being told that you have cancer, or even being told that you have high blood pressure, or that you have a treatable condition might be perceived as both unexpected and unwanted. Another definition in the literature is news that suddenly and negatively changes one's outlook about the future. So a young guy might walk in feeling great just for a checkup and come to find out his blood pressure is 180 over 98. He walks in fine, he walks out patient, a hypertensive on medication. And that might be really serious news for him. Okay. There are different levels of serious news, right? I was a general internal medicine doctor. I took care of patients in the clinic and also in the hospital. I hardly ever had to tell a patient that I counted 32 of them on one lung before I quit counting them. But now and again, I would. I remember a young woman who had a mass of lymph nodes when I did an exam, which surprised both of us. She was unaware of it, axillary lymph nodes. And we sent her for a biopsy, and she ended up having Hodgkin lymphoma. I had to share that news with her, right, before referring her to a hematologist, oncologist. And that was tough. And I had to do a little homework before sharing that news because I'm not an oncologist. I don't diagnose that. In case she had questions about therapy or survival rate or whatever, I wanted to do my homework. So you might be feeling like this doctor from the New Yorker magazine. He says, "There's no easy way I can tell you this, so I'm sending you to someone who can." You know, those of us who don't want to rock people's boats or ruin their days, or maybe we're conflict avoidant or what have you, we may wish that we didn't have to do this. But if you're the patient's identified physician, either their primary care doctor or their hospitalist, or their specialist, whatever it is, if you're the one, you're the best one to do this. So it behooves you to learn some skills so that when you have to do it, it will go well. Because sometimes it doesn't go well, but that needn't happen. At the end of this workshop, my hope is you'll feel prepared. So why is this important to talk about? Well, the literature is very clear that this literature, I'll say, is from the United States, so I can't speak to other countries and cultures. But in the United States, most people want to know. All right. Not everybody wants to know, and we do in the US have the privilege of caring for people who come from different parts of the world. Um, and some cultures, Japan, for example, patients aren't told of cancer diagnosis. The family's told, but the patient isn't told. And that's just the way many folks in that culture work. Um, we know from the literature that it strengthens the doctor-patient relationship, it fosters collaboration so that plans can happen, and it permits families and the patient to cope, right? Cope with the present and plan for the future. It's very important rather than being blindsided when you're on your deathbed. Uh, the model of serious news communication that we'll be talking about builds on what we've been doing the last 3 days, that five-step model of patient-centered communication. Um, it uses the same patient-centered skills to establish the relationship, to seek out emotion, and to respond empathically, right? To nurse the emotion. You guys are familiar with that now. The six-step protocol is as follows, and I'll do a deeper dive on each of the six steps. Preparation. What does the patient already know? What would the patient like to know? Sharing that news, and then responding to patient's feelings before finally planning for follow-up. Okay? This order is very important. So let's talk about the beginning, preparation. Plan what you will say. Put your ducks in order. Know what the current literature is on treatment, on morbidity, mortality, just in case your patient wants to know the answer to those questions. Don't think that every patient wants to know that level of detail when you've broken the news, and we'll talk about that. Unlike that New Yorker cartoon, do not delegate this, and try to create a conducive environment. In the hospital, you might commandeer a family room or at least draw the curtain between two beds in the hospital so that there's some sense of privacy. Okay. A lot of adequate time. Um, I would hand my hospital phone to a colleague if I had to communicate serious news. The last thing you want to do is receive an urgent page, an urgent message right in the middle of this, transcendent activity, if you will. Uh, Determine who else the patient would like to be present. This is super important. You know, a woman might want her husband present for this, for any serious news to be communicated. And imagine how challenging that would be if you're holding the bad news behind your back, if you're holding the CT scan results behind your back. You already know. So this is work that's best done before you order the CT scan, right? You might language it as follows. You've come in the hospital feeling pretty poorly for the last few days. We're going to do a number of tests. We're not sure what the results will be, Is there somebody you'd want to have with you as we share the results of these tests with you? Right? So much easier to say that before you order the test than when you're holding the test results behind you. Although sometimes in medicine, that's exactly the situation you find yourself in. So you have to figure out a way to language it. This next step is so critically important and so often missed by well-intended physicians. So I want you to really think about this one. It's important to figure out what the patient already knows. And obviously in pediatrics, if for a young child, that would be predominantly or at least partly what the parents already know or suspect. The reason this matters is that some patients will actually break their own serious news if they've suspected that their weight loss might be due to cancer, and sure enough, it is. If you ask them, you know, what's your understanding of what's been going on, or what are your thoughts about why you've been having these symptoms? Sometimes patients will actually do the work for you. And for those of us who don't want to hurt somebody's feelings, it's much easier if they sort of do it themselves. On the other hand, patients may have magical beliefs, and you're going to have to start at a much earlier point in your discussion than you imagined, right? So it's really, really important to know. It's also uh, very important to understand whether or not the patient is able to hear or receive more bad news or bad news, difficult news. Um, I admitted a young woman, 35-year-old woman who was a nurse's aide, um, and she was married and had two young, three young children. And she was admitted to the hospital urgently through the emergency room with some rectal bleeding. And the story sounded a lot like inflammatory bowel disease, Crohn's disease, or ulcerative colitis, or something like that. And so we told her that we would want to do a colonoscopy because this could be inflammatory bowel disease. And she was a nurse's aide, so she knew it's not a good thing to have inflammatory bowel disease, especially this was several years ago before there were biologic treatments. So, it's a chronic disease it really changes your life. So that was serious news for her, just the thought that this might be inflammatory bowel disease. And so the gastroenterologist did the sigmoidoscopy and saw some friable tissue biopsy. He said, yeah, it looks pretty angry. So we had to wait for the biopsy result to come back. And the woman's husband was in another state on business. And we got the biopsy result back, and it was adenocarcinoma. And she didn't want kind of any more news until her husband came back from the business trip, and we respected that. But it was very difficult to sit on that news for 2 more days, waiting for her husband to come to support her in receiving this difficult news. And in the interim, we did a CAT scan, and sadly, her liver was studded with metastatic disease. So she had stage 4 adenocarcinoma at age 35. It was really, really tragic. But waiting was hard on the team, right? She didn't know, um, but it was the right thing to do in that instance. So rescheduling if the patient's unprepared. So this is a super important step, and it should be an open-ended question. What's your understanding of where things stand, in your healthcare, or why you've been so sick? What are your thoughts about it? Remember, in the 5-step model, beliefs is one of those tools you can use. What do you think's going on? And to kind of not only understand not the situation, but to get toward emotion, which will be so important in this model as well. The next step is also important. How much does the patient want to know? It's important to recognize different preferences, right? Uh, Patients might decline to receive information themselves. They might delegate their spouse, their grandchild to to be the receiver of news and to make treatment plans. Has anybody had a biomedical ethics course before? Yeah. What would you say is the predominant or preeminent biomedical ethical principle in the US, Canada, and most of Western Europe? Is it beneficence? Is it autonomy? Is it non-malfeasance? Is it what's the fourth one? I can't remember, but huh? All of them together are important. My experience in medicine in the States is that people tend to feel like autonomy is the primary, the preeminent one, right? We're not paternalistic anymore, which is what beneficence. So, but autonomy doesn't mean that every patient must be a full and equal partner in their care, right? And a lot of people misinterpret autonomy as meaning that everybody's got to know, you've got to be 100% informed and really engaged and shared decision making and everything. Autonomy means a patient gets to choose whether to be a full and equal partner in their care, or whether to let their grandson make the decisions, or whether to let the doctor make the decision. They may ask you to be beneficent, right? Which is an uncomfortable position for many physicians in the 21st century because we're so used to patients wanting to know. But some people don't want to know. And if you shove the bad news down their throat, that is not patient centered care. So they might designate someone. And people handle information differently, and their desire for how much information they want is really dependent on a number of things: race, ethnicity. I mean, race being a social construct, of course, but ethnicity, culture, religion, SES, age, developmental level, um, level of health literacy, etc. Right? Prior family experience with the healthcare system, and maybe with a similar diagnosis. This all plays a role, and we need to be sensitive and to that and respect the patient's preferences. So we've prepared ourselves by getting some information ready in case the patient asks questions. We found out what the patient already knows. We found out how much they want to know. And now finally, it's time to share the news. Okay. Notice that it takes some preparation before sharing the news. Okay. So how do we do this? The literature is very clear that a warning shot, if you will, a warning shot across the bow, a preparatory statement, is helpful prior to sharing the diagnosis. Okay. In the poem, it doesn't look good, he said. It looks bad, in fact, real bad. That's a warning shot, right? Now, here are some others. I'm afraid I have some serious news for you. This is more serious than we thought. I'm afraid the news isn't good. I wish I had better news for you. That's one of my favorite ones. I wish statements are so powerful because they show that this matters to me. Okay. So just kind of prepare the patient. It's a bit like letting the patient steel themselves before the blow to the solar plexus, right? So they don't get the wind knocked out of them. They can just prepare themselves. If you have to do this on the phone, which sometimes happens, you're on at night and the patient who you don't know anything about codes and you're helping to run the code and the patient doesn't survive and you have to call next of kin, you know, these things are really important. These steps matter in telephone medicine as well, including are you sitting down? Maybe. Yeah, very challenging. So then this is such an important sub-step of step 4. Say the news unambiguously and then stop. Okay? So the growth turned out to be cancer. If it's cancer, you have to use the cancer word, the C word. If the patient in step 3 said they want to know what's going on, don't say the growth turned out to be a tumor or something. Don't sugarcoat it because the patient won't really know what's going on if you do that. We tend to do that to make it easier on us, thinking it'll make it easier on the patient, but it's not in the service of the patient. Okay. Of so here's what the overwhelming tendency among physicians is when breaking serious news. And I've done this myself before I kind of got schooled in this. So Mrs. Jones, the bone marrow biopsy showed that you have a type of lymphoma. But don't worry, we're at a great cancer center here, and there are several trials you can enter in, and I think some of them have been very successful. And there are some new biological medicines on the horizon, and I think they're going to be, and that's what the patient hears, right? I'm just dumping this ton of information, trying to make myself feel better, right? What is the patient hearing? Right? White noise. Once you tell someone that they have a serious diagnosis, they shut down. Even in the poem, and he said something else I didn't catch, and not wanting him to have to repeat it and me to have to fully digest it, I just looked at him for a minute and he looked back. It was then I jumped up and shook hands with this man, etc. Right? So Once you say the bad news, you must stop and you must hold in that urge to kind of provide all the news about what you're going to do about it. Okay. So let it sink in. Take a few beats of pause. And as I mentioned, don't minimize the severity if it's severe. Okay. Now, what do you think might happen if you say the bad news and then you stop rather than going on with your data dump about all the diagnostic and therapeutic next steps? The patient might actually express some emotion, right? And that's scary to a lot of doctors, but shouldn't be scary to you because we've just spent 3 days talking about the importance of getting emotion on the table and what you should do with it once you've gotten it, right? Maybe one thing I didn't stress yesterday or Tuesday, when people express an emotion, we don't have to fix it. That's not our job, right? And yet it's a challenge for many doctors and nurses and other health professionals because that's why we get into the profession. We want to find it and fix it, right? Make the diagnosis and fix the problem. If fixing's the only tool in your tool belt, you will be short a tool many, many times in your profession. Witnessing to, empathizing with is a powerful tool, even if the problem is fixable. You've got to empathize before the fix if you want to be a healer. And in situations of serious news, getting the emotion on the table and simply witnessing to it by nursing the emotion, name, understand, respect, support, is such a powerful, powerful, and therapeutic skill. Okay. And what's interesting is the what kind of emotion you might experience. You could imagine that if somebody receives a cancer diagnosis, maybe the emotion would be what? Sadness, right? Tears, yeah. But that's only one possibility, and you need to know that there are other emotions that you might suddenly get hit with that can be surprising, right? So we think of affective emotions like tears and sadness, but some patients will have an outpouring of love. Heaven knows why, but it can happen. Yeah? Or relief. Oh, I am so grateful to know that it's something. I thought I was going crazy. Right? So that might be an experience that you'll see, an emotional response that you'll see. Many patients, and interestingly, many doctors who become patients will have a cognitive response, right? Well, where should I go for a second opinion? What are the latest trials? And that's just a way to protect the psyche, right? That a lot of physicians just live in the cognitive world and not the affective world, and that's their go-to. It's not bad. It's no worse than any other response, but it's different than what you might expect from the average patient. But a cognitive response that can be very shocking is denial. There's no way that's my pap smear. The lab made an error. You're not telling me I've got cervical dysplasia. That there's no way that's happening. I've heard that, right? Denial is another way for the person to help protect their psyche, to help keep themselves together. So denial in the short term is not a bad thing. But if denial persists, we're really running into a problem here. We need to work through that with the patient or with a delegated family member, for example, if the patient just can't move past their denial. Blame, you know, you did this to me, or you should have found this earlier. That's another response that can kind of go, whoa, kind of shooting the messenger. It's how it feels as the doctor. But it's okay. If we know these kinds of responses can occur, then we can not be so shocked by any given response. The last one I want to talk about is the psychophysiologic response, also called the fight or flight, more commonly these days, even called the fight, flight, freeze response. All right, where an action potential is triggered in the person and they just go or get aggressive or what have you. So here's a short story. I was an intern at Bellevue Hospital in New York City in 1986 at the height of the AIDS epidemic before we had a single medication to treat that infection. And it was a very challenging time to be a house officer or resident because patients my age and younger were dying every day. It was just awful. And it was pre-work hour rules. So I was working 110, 120 hours a week, and we were expected, after having been up all night without sleep, to go to clinic that afternoon. So it was one of those nights where I'd been up on call the night before, had zero sleep because everybody was decompensating all night long, and had clinic. So I'm really, almost hallucinating at that point, right? Up 30, 40 hours, something. And anyway, I pulled a chart from the door, the patient I'd never seen before, and I didn't even open it. I walked in, I introduced myself, and I said, "So, what's up? What are you here for?" And he said, "Oh, I'm here for my HIV test result." And so I opened up the chart, and there it was, a positive HIV test, which 1986 in New York City was a death sentence, right? I mean, people were jumping out of their high-rise apartment windows with that diagnosis back then because there it was a death sentence. So I said, "Wow, I'm sorry to tell you that right here that your HIV test is positive." And then I looked up and I found myself alone in the room. This guy like disapparated. He went so fast that in my sleep deprived state, I like couldn't even register that he'd run out the room. So I ran into the waiting room and he wasn't there. And I ran into the elevator lobby and he wasn't there. And I ran to the stairwell and he wasn't there. And I just came back to my room and just put my head in my hands. I was so overwhelmed. And honestly, I never saw this patient again. I have no idea what happened. But I had no idea that somebody might react that way. Nobody ever told me. So it was such a shock. So I want you all to know sometimes this will happen. All right. It probably will still be shocking, but at least you'll have some awareness. Oh, yeah. I remember Fortin once said this can happen. So it's really, really important to know the range of emotions. So be prepared for strong outbursts, right? And a broad range of possible emotions, right? So knowing it will help you. Give the patient some time. Don't feel like you have to rush to next steps right away. Allow the news to sink in, okay? And if the patient doesn't spontaneously put emotion on the table, which is a metaphor or an image that should be familiar to you by now, use your quiet listening skills and encourage a description of feelings, right? You know the emotion seeking skills, right? We've talked about using direct skills like how are you doing with this news emotionally? How's this landing on you? Tell me how you're feeling right now. Or you can do it indirectly. You can ask about personal context. How's this going to affect things for you at work or at home? Um, you probably know that in many cultures, the U.S. is an example of it. Men are not encouraged to share emotion. Uh, in fact, men are encouraged to share only one emotion. And what emotion might that be? Anger, right? Yeah. But remember that anger is fear's bodyguard, right? Anger is the thing, as a guy, I'm allowed to show up with. Because if I show up with fear, I'm going to get eaten alive, right? In the culture. So anger becomes a proxy for every other deeper, more authentic emotion that I might be feeling. And I'll be very lucky if I have a doctor who recognizes that truth and gives me time and space to figure out what emotion am I really feeling that's deep to and more authentic to the anger. Anger is a secondary emotion, but I want to, as a physician with my patient, find out what's their primary emotion, what's really going on. Because when I empathize with that, that's a lot more powerful and therapeutic. So coming back to men, a very good thing is to say, wow, yeah, how's your wife going to handle this? And then the husband, the guy, the patient, can think about how his wife will react. And psychologically, that opens up some neuronal channels. So then you can say, oh, wow, that sounds like she's going to be pretty upset. How about you? And now suddenly he's able to figure out how he's going to feel, having thought about how his wife might feel. If you get that, it's just creating some psychological space for him to be a bit more introspective. having entered the emotional realm, because you know that in many cultures, men are not encouraged and are frankly discouraged from living in that emotional realm. But it doesn't mean they don't have feelings, and we do them a disservice to think that it doesn't matter to them, and we don't have to go there as doctors. We have to go there regardless of gender, regardless of sexual orientation, sexual practices, whatever. It's important to check in on it. So once we have the emotion on the table, remember that we want to ask, say more about feeling worried. Tell me more about your fear, whatever, using the word the patient used, right? And then once we understand it, now we can empathize with it. Because remember, empathy is the ability to communicate one's understanding of another person's emotional state. So I can't communicate understanding until I understand. So say more about blank is a helpful thing to do before empathizing, nursing with the emotion. So remember, nursing is simply naming, usually renaming the emotion the patient put on the table for you, making a statement of understanding. I can see how it would make you feel that way. Respect the patient. This is tough. You know, this sucks is a respect statement, and a very honest one often in serious diagnoses, right? I wouldn't use that with every patient, but there are patients I might have a rapport with where I can tell that that's going to land well, right? And then offering support. Notice that the support statement isn't trying to make it all nice. It's not putting a band-aid on it, right? It's not saying, oh, I'm sure everything will be fine. That's a tendency many of us have in healthcare, is to minimize or negate the emotion by, trying to patch it up and make it all pretty and nice. That's not helpful to patients, right? It's better to just be with them with their hard emotion rather than trying to take their hard emotion away. Does that make sense? Yeah. Okay. So finally, having addressed the emotion, patient might be in a place where they can hear about next steps. Where do we go from here? Some patients are going to jump to that right away, but most patients will benefit from a moment to really tune into their emotions and have that addressed through caring, empathic communication. So maybe there's additional tests that we need to do, more imaging or what have you. We might need to treat some symptoms. We might need to refer to a specialist or subspecialist. It's very helpful in these moments to discuss sources of support, including people's spiritual or religious beliefs. Notice in the Raymond Carver poem, are you a religious man? Do you kneel down in forest groves and ask yourself, do you kneel down in forest groves and ask for help at those moments? Yeah, that's kind of a poetic question, but there are ways to explore. Do you consider yourself to be a religious or a spiritual person at all? And the reason, and they might say, why do you ask that? And then I'd say, well, for many of my patients, their religious or spiritual beliefs can be a source of great comfort at these times. And honestly, for some of them, they can be a source of harm. I'm just curious where you land in this. Right? It's helpful to give your contact information and schedule a follow-up appointment. Okay. Sometimes patients are so shut down after hearing the news that they don't have any questions for you. And then they go home, and then all of a sudden, these thousand questions show up in their mind, and can create a lot of anxiety. Right. So if they have a way to get in touch with you that might be different from, call the clinic between 8 and 5. I've, for example, given my cell phone in instances like this so that if at 7 p.m. and I'm not on call, I'm home, but I know how important it would be at 7 p.m. if this person or their partner has burning questions that really shouldn't have to wait until the clinic opens up the next day. It's that little extra step that can really make a difference. It's also important before, say this is in the outpatient setting, before the patient leaves, to assess the patient's safety and supports at home. I was 1 year out of residency, and I was in the Navy at the time. I had a medical school scholarship for 3 years of my med school. And so I was in the clinic in the Navy, and one of my patients was this very sweet woman who was the wife of a retired gunner sergeant in the Marine Corps, and she was very hypochondriacal. She always had these different symptoms, and she was very, very tiny, very small. And I always got the sense that when I walked in the clinic, I was in the presence of a bird, a little nervous bird who might fly away at any moment. That was the feeling I got about her. But she was very sweet. And because she was hypochondriacal, I saw her a lot because there was always something she was worried about. And one day, took care of whatever problem she had. And she said, Doctor, would you see my husband? He's been having some urine issues. And I said, I'd be delighted to see your husband. Was new and I was building my practice. So he came in the next session because I had the opening. And as tiny and frail as he was, this guy was the exact opposite. He was about 75, but he still had the Marine Corps high and tight haircut. He must have worked out 3 days a week. He was as buff as anything you could imagine, and he was severe. If you know gunnery sergeants, I mean, this guy was all business. You know, you wanted to be on his team, not his opponent for sure. Right? And he was ramrod straight. And he told me about his symptoms. And, I thought this is probably benign prostatic hypertrophy, BPH, which happens to men as we age because the symptoms really sounded like that. Uh, and as part of my physical exam, I did a rectal exam and was shocked when I felt a hard nodular prostate. There was nothing this could be other than significant prostate cancer. It was hard as a rock and very bumpy. And, I was new in my practice. I didn't have communication skills that I have now, and nobody ever taught me communication skills when I was training anyway. And I said, you know, I think we need to see. I didn't want to share anything that I didn't know for sure. So I didn't know it was prostate cancer, but I knew it was prostate cancer. But I said, let's send you to a urologist for an urgent visit and see what they say and follow up. And so he went to the urologist, and the urologist repeated the rectal exam and said, Mr. Jones, this feels like it's probably prostate cancer. Let's bring you in for a biopsy in the next couple of days. And Mr. Smith, the patient, said, thank you, doctor, and went home. His wife was out. He wrote a note. He brought his shotgun to the laundry room, which had tiles everywhere, so it would be easy to clean, and he blew his brains out. But I didn't know that. The next day, yeah, because the urology appointment was the next day. So that later that day, I get a call, and I said, hello. And he said, who's this? I said, this is, he said, are you Dr. Fortin? I said, yes, I am. Uh, who are you? And he said, I'm Sergeant Anderson from Homicide. Mrs. Smith just found her husband dead of a self-inflicted gunshot wound in their home. And come to find out, the note said, I can't bear the thought of living with cancer. Now, I don't know if the urologist assessed for safety or not. This was in the late 1980s. It's probable that he didn't because it's not something people tended to think about, 35 years ago or whatever. And I don't know if it would have made a difference if he had. However, the literature tells us there is nothing more deadly than an old white guy with a gun. We know that suicide by firearm is a very common means of exit among white men in the United States. And Black and Latino and Asian men, the numbers seem to be less, but it would have been helpful, I think, to assess safety, see who's supporting, see if he has a handgun at home or a long gun, and check it out. An interesting factor is that sometimes denial or just shutting down is so strong that you have to repeat the news in a future visit. I've had several experiences over the course of my career where a patient would come in for follow-up. My agenda was to kind of, figure out where we went and see what the consultant's, report was and things like that. And the patient is clueless that there's anything wrong with them. Denial was so strong that I actually had to share this serious news again at the next visit to try to get through the barrier of denial. That's surprising, right? But if you know it can happen, you won't be shocked. There's a difference between being surprised and being shocked. You might be feeling a little down at this point, thinking, how am I ever going to do this? What if it's a serious a deadly illness, one of our jobs is to find and then provide realistic reassurance and hope. Okay. And hope, well, the reassurance is easy. I'll be there for you. I'll be there with you. You're not going to be alone. We're going to figure this out together. All right. The hope can be more challenging. And hope is dynamic. Early on in a serious illness, say such as cancer, it might be hope for a cure. Later, it might be hope for a prolonged remission. Later, it might be hope for reconciliation with estranged family members. Later, it might be a hope for a pain-free death surrounded by family members. So, one of our jobs as doctors is to figure out where's the hope here and offer that to the patient. It's never hopeless, all right? But sometimes we have to work to find the hope with the patient. Obviously, the patient's coming up with this, not us. All right. So, what I want to do is just show you a demonstration video. There have been a lot of videos made about communicating serious news, and none of them are perfect. And many of them are deeply flawed. And most of them are scenarios that are simulated with actors, and you kind of see right through it. It's kind of like a bad soap opera. And I want to show you a video that's several years old now, but it's of an actual clinician-patient encounter. All right. This is from a public television series called Wide Angle, I think. And it will, in this particular episode of this series, they were talking about the guerrilla war in Mozambique. And the scene we're going to see is a young couple coming into the healthcare clinic for the results of their HIV tests. And this is in an era when there was antiretroviral treatment. And through PEPFAR and other programs, it was available to people and effective. And this is a documentary, and it's about 4 minutes long. And I have no idea if this clinician ever learned about a six-step model for providing serious news, but I think if you watch it, you'll recognize that. Um, is it going to work, or we need sound? Yeah. I think when you watch it and if you follow along on the card, you'll see that she assesses the patient's prior knowledge, step two, finds out how much the patient wants to know in step three, shares the news, and then in a culturally appropriate way offers empathy. So while it's still not a perfect video, it's an authentic video, and I think it's worth seeing, even though it's kind of hard to watch. Great, thanks. Let me flip over there and oh, uh, let's see. There we go. Ooh, let's see. I gotta turn the volume up. Volume's all the way up. We can pause it if you want.
Did your husband tell you why you were
Okay,
coming here?
great. That's fine.
To find out the results? The ones we did for the AIDS test. Now I want Maria to tell me what she knows about the virus. What's HIV? What I hear is that it causes things. First, you get boils, then the person starts to lose a lot of weight. And among your friends, when you hear so and so has AIDS, what do other people think? What do the people in your neighborhood say? They say that when a person has that disease, you can't share food with them. You can't touch them. That's a lie. Those are all lies. The virus is transmitted through sexual relations, through blood, but you're still very worried. Come on, talk to me. I'm a woman like you. Come on, talk. Show me that pretty smile. Talk about your fear. What fear do you have? That you're going to tell me I have the disease. If you were sick, would you prefer it were hidden from you? No. What would you prefer? To know. Why? To get treated. Give me your hand. Your results came back and they were both positive. Both of yours. Yours and his both came back positive. What did I do? You didn't do anything. It's not a punishment. It's not the devil. It's not an evil charm. It's a disease that all people can catch, okay? Oh, dear God. Breathe. Come on. Breathe through your mouth. Breathe. Put your arms up. Breathe out. In again. This is a disease that anyone can get. I've already explained to you how it's transmitted, but I can't tell you if you already had it or if he had it. He was already in the jungle sharing razors with others. Oh, God. Maria, what are you thinking? Maria, don't blame your husband. You can cry, Maria. That's fine. We need to be brave and work together with the doctor because we need the help of the person who gives us the medicine and who knows about the disease. I don't think you need to worry about where the disease came from. You need to worry about what you're going to do from this point on.
Ooh, hard, huh? Very hard work. I feel bad for the husband. He kind of got left out, but you get the sense for the importance. And notice how she asked what she knew. She asked how much she wanted to know. She shared the news, and then the emotion came out in waves. Yeah, and she addressed it with some empathy. Again, not a perfect video, but it really shows how this can happen and this work. Uh, Whenever I see a video like that, I get pretty blue and feel pretty heavy. And I think it's important to spend a moment talking about us doing this work. We spent the whole time talking about our patients. So it's important to understand our own emotions that might happen when we share serious news with patients. And just like our patients, we might have a range of emotions that we experience, right? We might feel sadness, anger, guilt, a sense of responsibility. What if we forgot to order a screening test and then later a patient comes down with a disease? We might feel terribly guilty, right? We might see ourselves as a failure. It's not true, but it's understandable how one might see oneself as that. We're all human beings and none of us is perfect. We do our best and under the circumstances every day. It might cause one to question their own spirituality or beliefs. Imagine the pediatrician sharing with the parents of a 2-year-old that their child has a serious leukemia, right? And might wonder, where is God in all of this? Makes sense, and it happens sometimes. What about crying? Hmm. I didn't used to have this bullet on this slide, but somebody would always ask about it. Some of you, I can guess, will never ever feel like crying with your patients. It's just not who you are. It's not the world you live in. And others of you might feel like crying fairly often with your patient. There's a range, right? And crying, if it's authentic, is absolutely fine. I've cried with patients. I've cried with family members of patients in the ICU. Um, and you might think, oh my God, if the doctor cries, the patient's really going to think his goose is cooked. But that's not what happens. Right? Got a card from the family of a dear patient who died in the intensive care unit, and I'd spent some time. I'm not an intensive care doctor, but I would go there just to touch base with my patient and with the family, and got a card with my patient's picture, and they said, despite the diagnosis and the surgery and the chemotherapy and the radiation therapy and the ICU, the thing we remember most as a family is when you cried with us before she died. This is a very touching card to receive. Here's a tip though. Sometimes you'll feel like crying because of deep empathy with the patient and their family. Sometimes you'll feel like crying because this is somehow reminding you of your own life. My patient might remind me of my mom or something like that. And the tears are not really for the patient, but they're for me because of thinking about my mom. And in those moments, I just do a quick gut check and I say to myself, Fortin, who are these tears for? And if they're for the patient, I allow myself to cry. But if they're for me, I try to keep a lid on it and then do my crying in the break room or in the stairwell or something like that, right? Because I don't want to hijack this moment from the patient. So that gut check has served me well over the years. It's important to get support from others. In medical school, you have a ready built community. When you're medical residents in whatever specialty you choose, you'll have a ready built community. And then when you become attendings, you're on your own and you have to work to find a community to provide support. This is hard work. It's meaningful and rewarding work. But if you're all alone, it's really tough. So you might find a community of other healthcare professionals, or it might be a community through your church, or just a group of guys or gals who you get together with and can talk honestly about what's going on in your lives and your successes and your failures. It's really, really important. And there's important literature that shows that it helps to prevent burnout. So I just want to summarize by reading you a quote from Robert Buckman, who was one of the developers of this 6-step model. He says, if we break bad news badly, patients or family members may never forgive us. If we do it well, they will never forget us. So that I hope motivates you to learn this, to be good at it, to watch other people do it and compare what they're doing with the card that I hope you'll keep with you. And that should serve you very well. So I want to thank you very much for your attention this morning. And we've got about 2 minutes for questions, should there be any. What questions do you have? Yes, Jordan. Hmm. Hmm. Yeah. So the question Jordan asked is, what about in the pediatric situation where the family says, we want to break the news, but you're not sure that they ever will? In that situation, I'd say, it's a wonderful idea, and I'd like to be there in case questions arise that my medical knowledge can help to answer, something like that. Yeah. Um, if the child's very young, it might be okay that the news isn't broken, right? And parents can know their children well, whether the child is stoic or anxious or what have you. So I would definitely, for a young child, defer. As the child gets older, and if when you do your pediatrics rotation, you'll learn a lot more about this. But as the child gets older, because of the importance of autonomy, that applies even to kids. So there is a, 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 a movement to make sure that children are aware if they want to know, because it's their body, it's their life ultimately. Great. Okay. All right. Well, yes, last question and then we'll break. Yeah. Yeah. My first go would be not to try to solve this immediately and to use my favorite 3 words: help me understand. Right? She has a reason for this decision that I do not yet know. And I need to understand where she's coming from and how, whether she has any misinformation or lack of information that if I can help fill in those gaps or correct that misinformation, might change her ultimate decision. So often in medicine, we want to decide right away. Similar when a patient's in the ICU and everybody knows this patient's dying and the family says, no, this patient, you've got to do everything. You've got to do everything. And they won't allow the patient to be DNR, do not resuscitate. In those situations, you just have to meet the family where they are and say, help me understand, right? And it might be incredible distrust of the healthcare system, which is totally justifiable for certain folks, right? Um, and you need to work through that, right? And provide them with information. But it's a dynamic thing. It's not a switch it might be a dimmer that very slowly changes, right? And it's not a switch that gets turned on and off. It requires patience, which we often are lacking in medicine, but help me understand goes a long way. Tomorrow, we're going to talk about emotional intelligence and how we can work and increase our own emotional intelligence to make us even more effective clinicians. That will be about a 90-minute session. I think your schedule has time in it. And I'm sure you go everywhere with your phone, probably even to the bathroom, but bring your phone tomorrow because we're going to use an audience response system, which should be kind of fun. So make sure you have your phone with you. Thanks a lot. Enjoy the rest of your day.